to all of those that have joined us for the webinar today. I am Rajendra Maharaj, the Director of the Office of Malaria Research at the South African Medical Research Council. I will be the moderator for the webinar and will help guide and discuss the issues with input from both the panelists as well as the audience. Before we kick off with the introductions, just a matter of housekeeping. On your screen that you have logged onto, you will see the interpretation button right next to the record button and in the same line as the share screen button. Click on the button and please select whether you are Portuguese or English so you will get the correct translation. Please don't leave the screen on off as you will not be able to hear some of the presentations. Okay, so having said that, quick introduction to the webinar. The Malaria Elimination Aid Initiative of the South African Development Community is a regional collaboration by the, endorsed by the SADC Ministers of Health in 2009. The E8 consists of 4 frontline countries, Botswana, Namibia, South Africa, and Eswatini, and the second line countries of Angola, Mozambique, Zambia, and Zimbabwe. The E8 mandate is to coordinate and execute a regional malaria elimination strategy aimed at achieving the end goal of eliminating malaria in Southern Africa. Due to the high degree of interconnectedness within the region, countries that have reduced malaria to low levels are facing the challenge of persistent importation of parasites by cross-border travelers from neighboring countries that have a high rate of malaria infection. This webinar therefore focuses on the need for improved surveillance to reduce cross-border transmission across the E8 region. To start off the discussions, we have 3 presentations by esteemed scientists from the region informing about the access to prevention and treatment in E8 countries, using plasmodium genoming as a tool for surveillance, and looking at drug-resistant surveillance and the use of primaquine. So our first topic is going to be co-presented by Mukosha Chisenga and Professor Imo Kleinsmith. Their presentation will address access to malaria prevention, diagnosis, and treatment in border areas of E8 countries, results from an evaluation of malaria border posts in the second-line countries. Now, Mukosha Chisenga is currently a research associate at the SADC Malaria Aid Secretariat, Elimination Aid Secretariat. For the past 5 years, her work has been focused on coordinating various malaria research studies, both at country level and regional level, Professor Kleinsmith's main research interest is in malaria epidemiology, with an emphasis on vector control and malaria elimination. He holds dual appointments as Professor of Epidemiology at the London School of Hygiene and Tropical Medicine and as a technical advisor for the Southern African Development Community's Malaria Elimination Aid Initiative. So I hand over to you, Mukosha, to make your presentation. Thank you. You're muted, Mukosha.
Sorry for that. Thank you very much, Prof. Raj. I just want to confirm that you can see my presentation.
Yes.
Yes, we can.
So as Prof. Raj has mentioned, I'll be presenting on, or I'll be co-presenting with Prof. Imo Kleinschmidt on results from an evaluation of malaria border posts in second-line countries. Okay, to start with, the SADC region recorded over 3 million regular migrants, and these were traveling around the region searching for opportunities such as education, treatment, safety, and other reasons. But as we all know, malaria knows no borders, and conditions surrounding migration and inequalities in health access make migrants and even border residents living in these areas very vulnerable. So due to the high degree of interconnectedness between countries in the region, and through economic and cultural ties, population movement, and shared vector ecologies, the higher level of malaria transmission in the second-line countries serves as a reservoir of infection that is continuously imported into the four frontline countries. And this eventually slows down progress towards achieving elimination. It is with this background that the E8 in 2017, in collaboration with the various national malaria programs and with funding from the Global Fund, established 46 border health posts along 5 key priority borders. This is between the high and low transmission districts of the E8. The goal of these health posts was to reduce importation of parasites from second-line countries, to reduce importation of the parasites from second-line countries into the frontline countries, and to improve access of malaria prevention, testing, and treatment services. The health posts were intended to target 2 key populations that were potentially a high risk of malaria, and also would likely play an important role in the importation of malaria from high to low transmission countries. And these are the mobile and migrant populations, as well as the underserved residents of border areas. There were 3 models of these health posts. The first would be Malaria Plus. We have grouped this with the 1 leverage post that was based in Angola. This provided primary health care, as well as testing and treatment services. This was in a refurbished container and was static. The second was Malaria Basic Unit. This one was a bit more mobile, also providing testing and treatment services. And then finally, we had the Malaria Surveillance Units, which were providing active surveillance along border health districts. As of 2019, a total of 1.2 million people were tested in these facilities, with a total positive of almost 6% positivity. Okay, so following the implementation of these health posts, there was a need to evaluate them to determine the level of access to malaria diagnosis and treatment in border districts, the level of access to malaria prevention, such as IRS and bed nets in MMPs and residents, also to determine the origin and destination of migrant travelers and mobile residents, and finally, to determine the knowledge, attitudes, and practice for malaria prevention, symptoms, and treatment in both MMPs and border residents. I just wanted to add that this presentation will be focused on results from second-line countries, and ongoing work for the evaluation continues in frontline countries. As with all studies, we have faced a few challenges, and there are a few limitations around this study. Since its inception, the study has had to deviate significantly from the original protocol. The original protocol envisaged 2 rounds of data collection, one at the baseline and one at endline, which was intended to happen 2 years after implementation. However, funding was only secured for 1 round of data collection, and data collection was further delayed by lengthy ethical approval processes. So the findings of this report, or findings of this presentation, should be regarded more as a single cross-sectional assessment, representing basically a snapshot of the malaria situation in border areas. There is a bit of a difference in the frontline countries because we did have intervention and control sites, so this will form the basis of the evaluation of impact in frontline countries. As I mentioned, in second-line countries, no comparison is available, so therefore these results will be descriptive in nature. Yeah, just to give a bit of scope for the entire study, both frontline and second line, we've had 32 separate surveys of residents and MMPs. That's over 9,000 participants. We've had more than 80 focus group discussions, 140 in-depth interviews, and a 2-year retrospective data review. This only happened in frontline countries. Progress to date, 6 out of 7 of the participating countries have completed data collection. A report for the second-line countries has been completed, and we're happy to say is now available on the E8 website. Botswana and Namibia are compiling their country reports, and however, South Africa was affected by the COVID-19 pandemic when they were in the field, and this terminated their field work. So fieldwork for South Africa will resume in 2021. And following that, the frontline report will be completed. Okay, so this is just a map of our study sites, both in frontline and second line countries. As we mentioned, 7 out of the 8 E8 countries participated in this study, and the sites were along the 5 key priority borders of the E8 region. For second line countries, there was 1 study site per country, so that was 1 district per country as per study protocol. But in frontline countries, multiple sites were selected. I think I can hand over to Prof. Imo.
Good morning. Yes, thank you very much, Mukosha. So I will just present, could you just go back? A summary of the key results. And as Mukosha has just said, this report, which we're presenting this morning, is available on the E8 website. So you'll find far more details there. Obviously here I can only cover some of it, and I'm afraid also in short time. So we will be going through quite a lot of results in a short space of time, but you can refer to that report. I'd also like to just emphasize that the results we give in this report are derived from the data that were collected at each of the 4 study sites, 1 in each of the 4 second line countries. So there's no claim made that they are nationally representative. They are just for that particular site. And also perhaps just to emphasize that in second line countries, data collection was restricted to residents living near an E8 border health post. So we wanted to see how did this border health post affect their various malaria-related behavior and treatment seeking and so on. In the frontline country studies, migrants were also interviewed. So the results that I'll be presenting now are restricted to what I've said and are on residents in these border areas only. Can I have the next slide, please? So this shows on the left for adults, on the right for children, the treatment seeking for febrile illness, and the blue bars are the proportion who seek treatment for febrile illness or have done so over the 4 weeks preceding the survey. The gray bars are those who were tested with a blood test of all those who sought treatment. Well, in other words, they got to a health facility, reported fever. Did they have a blood test? The orange bars are those who were tested with the blood test out of all those who had fever. That's obviously a smaller proportion because not everyone sought treatment. And then the yellow bars are those who received treatment if they were found positive. I should point out that these were quite small numbers because obviously not everyone was found positive. And in the Zambian side, we don't have that bar because no one reported that they were positive. So obviously they weren't asked about medication. Of note here is that particularly in Zimbabwe, these proportions are very high, close to 100% sought treatment. Similarly, a very high proportion were tested out of all those who had fever and of course out of those who sought treatment, and almost everyone received medication. Next slide, please. So this is the first choice of diagnosis and treatment in the 4 sites. I should point out an error here. Unfortunately, we only just noticed that just before the webinar began. For Angola and Mozambique, it appears to show a very large proportion using the private sector. That is an error. In these sites, most people, as well as in Zambia, most people use government hospitals or government health centers or border posts, and a very, very small proportion. Somehow the numbers here gone up tenfold. It was 7% in Mozambique and 3% in Angola who reported using the private sector. So most people go to a government health facility, and these included E8 border posts. They didn't manage to distinguish between an E8 post and free services that are available through government facilities. Of note again is that in Zimbabwe, we have a very large proportion seeking treatment through a community health worker. And possibly that might be related to the fact that very high proportions actually did seek treatment and did get a blood test and so on. So Zimbabwe here shows a different pattern to the other countries through the use of community health workers. In all sides, people reported that their main reason for choosing a health facility is because of convenience, and that is basically because it's easy to get to. Can I have the next slide, please? This throws some light on how easy it is for people to get to health facilities, and it shows those proportions who required more than 45 minutes to get to a health facility, or on the left, it's who estimated that there were more than 8 kilometers from such a health facility. And the proportions are, so in most places, most people live close enough to a health facility that it takes them less than 45 minutes. The exception here is Angola, where a very large proportion took longer to reach a health facility. Next slide, please. So here we just show what people's responses were in terms of prevention through vector control measures. And the blue bars are the people who, the proportion of households who said that they own at least one insecticide-treated net. The orange bar is those who slept under a net out of those who own nets. But of course, not everyone owned net, and hence the proportion of those who actually slept under a net out of all respondents is smaller. And then the yellow bar is whether their house was sprayed in the last 12 months. Obviously that only applies in sites where spraying is actually the policy. And you can see, particularly in Zimbabwe, almost everyone reported in this site that their house had been sprayed. This is not a site where nets are generally used. So that is why we see mainly IRS here and a smaller proportion having nets. In the other sites, there was either a mix or exclusively net use the intervention. And whilst large proportions do have nets, there is also a significant number of households who don't have nets, even in places where this is the only intervention. When one looks further into this, we found that of those households who owned nets, most owned sufficient nets for what is the universal coverage criterion, namely one net, at least one net for 2 persons. So in the households who had nets, there appeared to be adequate provision, but not all households did have nets. And the nets were of variable condition. We asked about that as well. I think those details, you will have to go into the report. I can't really elaborate on them here. There are also details about the length of time since they last received a new net. Can we go to the next slide, please?
Mo, can you please wrap up?
All right. So then briefly, this slide is on local and international travel, and quite high proportions of people reported travel outside their district in the past 3 months. Of note is that many who said that they traveled slept outside during travel, and of those, very small proportions actually used any form of protection. So there's a clear danger here that people traveling, sleeping outside, have no protection against malaria. Next slide, please. So this slide just shows knowledge about malaria and its prevention. And I'll just summarize this by saying that most people had a good understanding of symptoms of malaria, of how to prevent malaria, of the potential fatal consequence of untreated malaria, and also, yes, I think that basically sums up the knowledge on malaria. If we can go to the next slide, please. So our key findings here are, I mean, there's some good news here, is that most people, not all, received a positive blood, received medication. A very high proportion received medication when they had a positive blood test. And most people also did receive a blood test when they went to a health facility. Lack of access to health facilities was quite rare, certainly not due to cost or mistrust. We did ask about that. And high levels of correct knowledge of causes and symptoms and prevention of malaria was also found. Treatment seeking was generally timely and access to diagnosis was reasonable, but a minority did not seek treatment or diagnosis when they had fever, and also a proportion didn't get a blood test. So that is something that needs attention, that in areas where there is malaria, people presenting with fever did not always receive the correct diagnosis for testing for malaria. What I mentioned earlier is that sleeping outside whilst traveling is quite common, and there's no protection for this, so there's a gap here for a prevention strategy. Next slide, please. So our recommendations for this, just to wrap up, are that the message about treatment seeking needs to be re-emphasized when people have fever in areas, even where malaria is rare. It should still not be excluded as a possibility. And the same goes for health post staff, that they need to test people who present with fever. Again, I think this is particularly a possibility in places where malaria occurs less frequently. Messaging should include use of protective measures, particularly when people are sleeping outside when traveling, and this could include nets, prophylaxis, repellents, and so on. We conclude from this that the border posts provide a useful service and should be extended to those areas that are currently not served by nearby health facilities, since this timely health seeking is dependent on easy access to such facilities. And lastly, we need better surveillance to assess the impact of cross-border travel on malaria transmission. Lastly, last slide, please. I'd like to acknowledge the malaria programs and partner organizations that were involved, and also the funders, in conducting these studies. And again, I refer you to the website where we have the report of the second-line countries. The frontline country report will be out sometime next year when we have all the data. Thank you very much, and apologies for going over time.
Okay, thank you, Mukosha. Thank you, Imo. I think that was an excellent summary of the report. And as Professor Kleinsmith said, if you want to access the full report, it is available on the E8 website. So in interest of time, we won't take any questions after the presentations. We could hang on to them. Once the three presentations have been made, we will take questions. Moving on, our next presentation is by Professor Davis Mumengweni, who is an associate professor within the Science and Technology Division at the University of Namibia. His research interests include, amongst others, malaria operational research, drug discovery and development from natural products, as well as drug development and diagnostics. Professor Davis holds a PhD in pharmaceutical sciences from the University of Manchester in the UK, and he will be addressing us today on Plasmodium genomics as a surveillance tool for monitoring local malaria transmission networks and importation in northern Namibia. Over to you, Davis. Davis, you are muted. Davis, can you unmute?
Okay, sorry about that. I'll just share my screen with you. Thank you for the opportunity to make this presentation. I am just going to talk to you about some of the work that we've been doing in Namibia, trying to see how Plasmodium genomics can be used to monitor malaria transmission. So this is a cliche, but it's really true that malaria knows no boundaries. And this is true of our E8 region. And as has been articulated in the previous presentation, it's a lot to do with human mobility, but also to do with mosquito mobility, which is the vector for transmitting malaria. So when we look at the graph lower down, we see that Namibia is part of the E8 countries, which are targeting to eliminate malaria. And I am just going to be focusing on Namibia. In Namibia, there's been a lot of progress towards malaria elimination. It's a low transmission country. And if we look back to when ACTs were introduced in 2005, we've gone down to only 3,000 cases nationally. But this has stalled a little bit, and we've had a few outbreaks here and there. As you can see, in 2017 was a particularly bad year, including also for the whole region. But we do feel we're on track to eliminate malaria, and our target is to achieve that in 2022. Malaria in Namibia is very heterogeneous, and most of it is in the northeastern part of the country, with 90% of all our cases coming from 3 regions: Kavango East, West, and Zambezi region. And they're all bordering Angola. I'll just highlight that there. So this is along our northern border with Angola. And if you look at the character of malaria on this graph lower down, you'll realize that the character of malaria in Namibia along the border is very similar to what is happening in Angola. So this presents a challenge to Namibia eliminating malaria. And part of this is because we have so many gaps in our knowledge of malaria. We're not really sure how much malaria is being imported, how much is being spread domestically. And so we're really unable to classify whether our infections are local and or imported. And to eliminate, you need to have that clear distinction of what cases are locally transmitted and how many are coming across the border. And another challenge that we face is we are trying to detect and treat all malaria cases, but at low transmission, it's not always possible, because it's been reported that at low transmission, we do have a significant number, up to 80% of our cases are actually asymptomatic. So we have what we call the hippo analogy, where all the symptomatic cases which present at health facilities look like the head of the hippo, so they're just to the tip. And then when we look below the surface, that's where most of our cases are. And we need to be able to treat both the symptomatic and asymptomatic cases, that is, get the whole hippo. So in order to achieve this, we need to be able to diagnose all cases, asymptomatic and asymptomatic. We need to be able to classify them as local or imported. And we also need to be able to tell how sensitive the parasites in country are to the drugs that we are using, the ACTs. And finally, we need to be able to know a little bit about the population structure of the parasites in country, and this will help us to look at some of the transmission trends which we would not be able to come to. And all of this requires new innovative tools to support better surveillance of malaria in aid of achieving elimination. And genomics can really address key challenges that have been highlighted here. Currently for surveillance, we detect all our cases at the clinic, passive surveillance, but we also are proactive. We do reactive case detection, where we follow all malaria index cases to their homes and try and find out if there are any other cases around. And one of the challenges, we did this study in Ohangwena region, and one of the challenges we find with reactive case detection is a lot of the information that we're getting from patients is incorrect. So we cannot follow up the case, where it came from, and treat it. But one thing we're able to show is that there is a distinct travel pattern. Travel is a strong risk along the border areas, and the strongest risk is in males between the ages of 15 and 35. And interestingly, we're able also to show that malaria cases do cluster around each index case. So what we sought to do in this study was to pilot looking at parasite genomics to answer some of the questions that reactive case detection wouldn't allow us to do. And we wanted to see whether Plasmodium genetics will allow us to monitor malaria transmission. So we wanted to determine how useful microsatellites, microsatellite markers would be useful in resolving differences between parasites. We also wanted to see whether we can tell whether there are genetic similarities with parasites at a local level and at a regional level, and be able to use this information to classify whether they are local to the geographic area where they're detected, or they're different, that is, they're imported. And we'd also like to quantify how far do these malaria transmission networks take place. And lastly, of course, try and evaluate to what proportion do imported infections contribute to local transmission, because this will give us more information on where to target resources for interventions to achieve elimination. So we collected RDTs and dry blood spots as sources of DNA for this study. And what we're going to try and do is look at 26 microsatellite markers across 23 clinics, starting from Rundu all the way to the end of Kavango East and including in Zambezi region, to try and, so this is where we collected our samples. And what was interesting is when we look at all the genotypes covered by the 26 markers. For RDTs, we needed up to 1,000 to be able to get the whole range of possible genotypes. But when we use dry blood spots, obviously because there's a lot more blood collected, we could be able to cover it with 200 dry blood spots. So what did we find? So if you look at this circle, we tried to color code it with the geographical area where the clinic where the samples were collected. So they all have different colors according to where they were collected, and that's how they would be related. And then the lines joining the different dots are also showing us that there's some interconnectedness between the parasites. And what we found is that there are genetic similarities within and between parasite populations at a regional level. When we look at a narrower area, which is such as the clinic, we find most of the similarity is between. And when we go in a wider area, which is the district, we get more local transmission. So there's highly interconnected transmission in northern Namibia, and the majority of transmission occurs within a district than within a region. When we look at the spatial distance or scale at which we can actually track relatedness of parasites, you can see that the closer the distance between the cases, the higher the similarity of the genotypes. But as we move further away, the similarity becomes less and less. But what is interesting is we could still track samples which were over 200 kilometers away and see how the parasites were related. Obviously, this would be because of human movement. I stand to be corrected, but I don't think mosquitoes can fly that far. So when we look at contribution of imported infections to local transmission. All the samples that we collected, we did ask questions about travel history. So there's self-reported travel history. And we found that the number of cases that were related, number of imported cases which are related to other important cases was only as low as 4%. So these are people who probably contracted the infection together whilst traveling. But when we look at relatedness from imported to local, this increases to 18%, and then local to local, 78%. So what this does tell us is that whilst the importation direct transference of parasites is not as high, but importation provides the seeding event that leads to local transmission. So if we're able to prevent this seeding, we'd be able to limit transmission. Now we try to also fingerprint the parasites which were collected at different clinics within Kavango region and Zambezi region, which is a neighboring region with a smaller commercial center. And when we looked at the similarities between the genotypes of the parasites, it was interesting to see that in Zambezi, only 60% of the parasites within that region showed that they'd originated within the region. And the other 40% could be traced back to Kavango region, which is actually having a big city, which is Rundu, and it's a commercial center. So you can already see how human movement is actually influencing how the parasites move between regions within the same country. And this is probably similar to what happens across national borders. So when we look more closely at the individual parasites within each malaria case, what we find is we look at the multiplicity of infection, which means how many parasites are actually infecting each individual. So the higher the number of parasites infecting you, it actually means that there are more parasites within that population, and you're at higher risk of parasites which are genetically distinct. You have polyclonal infections, and this actually leads to a higher risk of symptomatic malaria. It also leads to a higher risk of drug resistance. So just looking at the multiplicity of infection and how polyclonal the infection is, it tells us how severe malaria is in the area and how many parasites are within circulation. And I think you can see in Rundu, the biggest city amongst there is a lot more, a higher multiplicity of infection as compared to Zambezi region, where it's a lot lower, and this is what we'd expect at low transmission settings. When we look at heterozygosity, again, we're looking to see the diversity of the parasites within individuals. And the diversity in Zambezi is lower, which is what we'd again expect at low transmission. So this is a paper that we put together with Sophonius Tasima and Brian Greenhouse at UCSF. And it was looking at how parasite genomics shows the connectivity of malaria cases. And what is interesting, if you look at both panel A and panel B, is that when you look at the parasite genomics, it gives you a lot more information about what is going on with transmission. The genetic data has a lot more data than if you look at mobile phone records and how people are moving. And this is obviously due to loss of network or people changing SIM cards when they're in transit, but the genetic data remains intact. And also when we look at travel survey data, there's a lot less information and range over the movement than we get from the genetic data. So the conclusion here is parasite genomics can actually help us inform decision-making for malaria elimination using routinely collected RDTs and dry blood spots as sources of DNA. And we can use this to understand and quantify the burden of malaria and also importation, and also to see what is the range of transmission, not just how many cases are going on. We observed that there was moderate to high multiplicity of infection and parasite heterozygosity, which is not what we expected at low transmission. And we think this is probably due to the importation from our neighboring Angola. the population diversity of Plasmodium falciparum doesn't fit the model for pre-elimination settings, which means we maybe need to look at this closer and use a more regional approach than just a national approach to see what is happening with the malaria transmission.
Can you wrap up?
And high levels of parasite genetic diversity need efficient surveillance systems. So they can actually help us to monitor for risks of outbreak and potential resistance to anti-malarial drugs. So finally, what can we do with this information? When we look at the parasite Plasmodium diversity in Namibia, and we are able to link up and use a similar approach in other E8 countries, we would be able to understand the transmission dynamics of the parasite within the region. And this can be done with high resolution genotyping to accurately assign parasites to their source of origin. So detectable clusters of different genotypes means if we strategically design studies like this, we can actually identify parasites from different countries and use this information to make better decisions as a regional bloc on how to, what interventions we should put in place. This usually requires sophisticated infrastructure and highly trained personnel. And one way to get around this would be to establish highly sophisticated sub-regional laboratories and form them into a network where they feed into each other and samples are processed and the data is shared. Or we could use an approach of using nanopore sequencing, where we can actually do mobile sequencing using the USB size sequencer like the MinION. This has been reported in the literature that it has been used in the field to actually detect the different sequences or the genomics of the Plasmodium parasites. So if we're able to use these approaches, we can have a regional database to try and identify sources of imported infections and be able to put interventions in place where there is a higher risk of this occurring. So this work was conducted by the Namibia Malaria Elimination Partnership, which includes some of the partners here: University of California, San Francisco, University of Namibia, University of Texas Southwestern, and the Ministry of Health Namibia, and the London School of Hygiene and Tropical Medicine. And the funding to do this work came from the Bill and Melinda Gates Foundation and the Novartis Foundation. Thank you very much.
Thank you, Davis. That was a very interesting talk. And I suppose that genomics has become increasingly more important tool as we move towards elimination and we have to prove origin of infection. Thank you. Our final talk today will be delivered by Dr. Jayshree Raman. Jayshree Raman began her malaria career at the South African Medical Research Council after completing her postdoctoral research fellowship in Sweden. In 2014, Dr. Raman moved her research program to the National Institute for Communicable Diseases in Johannesburg, where in line with the national policy, her research now focuses on assisting South Africa and other SADC countries achieve malaria elimination. Dr. Jayshree will be talking today on anti-malarial drug resistant surveillance, Primaquine and E8 malaria border posts in South Africa. Jayshree.
Thank you very much, Raj, and thanks for everybody else. And I look forward to giving you a quick chat on answering a few questions that have been raised in the other two presentations, and also trying to operationalize using genomics in the SADC region. And I'm going to use South Africa as a use case scenario to show you what the surveillance units that have been put in place can be used to enhance our surveillance and accelerate the countries towards elimination. So if we look at South Africa, and this is a map from 1938, malaria was really widespread in the country. It came right down to Pretoria in Gauteng, and was way past Durban in KwaZulu-Natal. But with effective interventions, we've managed to push back the limits of malaria in the country, with it now limited to 3 provinces, basically Limpopo, the border regions in Limpopo, Mpumalanga, and KwaZulu-Natal. And this was primarily done using indoor residual spraying with DDT. And it's been very effective. And so let's have a look at how effective it's been in the country. So if we start from 2000, when we had the last major outbreak, and that was due to insecticide-resistant vectors as well as drug-resistant parasites. We had major outbreaks, and the country became the first country to introduce an ACT in 2001, which was Artemether lumefantrine, and DDT was reintroduced for indoor residual spraying. Since then, there was a major reduction in cases, and by 2007, the country had a malaria incidence that reached the WHO threshold for elimination. So the discussion started on whether the country should stop focusing on controlling malaria and move to a malaria elimination agenda. And an agenda was finally adopted in 2012. If you ignore the outbreak year of 2017, you can see that since adopting the elimination agenda, our malaria cases have never ever reached the level of 2007, emphasizing the fact that if the country wants to eliminate malaria, new tools needed to be added, and also there needed to be a clear indication of what was sustaining the residual transmission in the country. So as you've heard in the previous 2 talks, obviously people movement was given as one reason for possibly sustaining this, and this was by people carrying mosquitoes or parasites across borders. And a good indication that this was possibly true was done by some mapping of mobile movement across the SADC region, which emphasized the interconnectedness of the region and showed that people move in vast numbers, mainly between the economic hubs, and that could possibly be a reason of great parasite movement from high burden areas to elimination areas. As Prof. Davis has shown that in his talk, that there was a movement between Angola and Namibia. We did a study in KwaZulu-Natal and had a look at community malaria as well as malaria from people moving across the border. And what this study showed that of 97% of the cases detected were detected at people crossing an informal border between Mozambique and South Africa, which emphasized the importance of these surveillance units in detecting these malaria cases. And these border units across the region have strengthened the global technical strategy for malaria in terms of addressing the 3 pillars. First, they ensure and increase universal access to malaria treatment and diagnosis. They also help to enhance elimination strategies, and I will discuss the one case in South Africa in terms of single low-dose primaquine. And then by virtue of being surveillance units, they have transformed surveillance into a core intervention and increased surveillance in their area to improve malaria elimination efforts. So the border units that have been put in the E8 unit since 2015 have greatly reduced malaria incidence and mortality in all border regions, but particularly if you look at this map, which was done for this year, in the eliminating countries, which are Namibia, Botswana, South Africa, and Eswatini. And this really has helped advance these countries get closer towards their elimination targets. Very interestingly, in South Africa, besides reducing the malaria burden, these surveillance units along the border have also helped reduce the local transmission. And this is really through the single low-dose primaquine program that was launched. So following a clinical trial in the country and then finally regulatory approval, in 2018, South Africa formally started deploying single low-dose primaquine in eliminating districts. So that was everyone that was diagnosed with uncomplicated falciparum malaria got the standard ACT treatment plus primaquine. And initially, when we started rolling out this program, there was some concern that we would not reach about the 80% coverage that was required to ensure that it would have some impact on transmission and that we'll be able to maintain this coverage. But the surveillance units have done such a fantastic job in doing active case detection that they have actually given out over 80% of the doses in both of these districts, and actually maintained an 80% coverage and had a major impact on local transmission. So if, as you can see in Mpumalanga, they've had a massive drop in local transmission since Primacon was introduced. And by the 2019 and 20 season in Mpumalanga, the local cases only contributed about 1% of all cases reported. We had also a similar decrease in Kamiakudo district in KwaZulu-Natal. However, in the 2019-20 season, there was a slight increase, but it was still much lower than pre-intervention. So in terms of this, using the surveillance units just not to stop, to test and treat, but also add a transmission blocking agent to their arsenal, actually help the country move much closer to its elimination target. So next is that for the surveillance units to be very effective is that they have to be able to detect malaria, and they use the currently most widely used point of care diagnostic, which is the rapid diagnostic test. In most of the SADC region, falciparum malaria is the most common species, so most of the RDTs are falciparum specific, and they use the HRPT2 gene to detect malaria infection. But the malaria parasite is very desperate to survive and has managed to evolve a deletion in the HRP2 gene, which means that it can evade detection by these HRP2 based RDTs, which will obviously negatively impact the effectiveness of the border units. And if that's not bad enough, there have been numerous reports from this year of where parasites in Africa have evolved mutations that are associated with artemisinin resistance. It's been confirmed in Rwanda. There are reports from Uganda and also Ethiopia. So they're definitely spreading, which means that we have to have very clear knowledge of our parasites in terms of their diagnostic and drug resistance if our surveillance units are going to be effective to be able to test and treat. So taking this into consideration, we've enrolled all the border surveillance units into our program, which we call Smart Surveillance for Malaria Elimination. And it's a very basic program where all malaria positive patients, there's a blood spot that's collected from them, as well as the rapid diagnostic test that came positive is collected. They both have a unique patient identifier put on them. In addition, that identifier is put on the malaria case notification form. So that enables any resistance data that is generated from the blood spot or the rapid diagnostic test to be directly linked to the patient. Also, the case notification form has a point where we get the patient's information in terms of where they reside. And that allows us to map down to the facility level or household level of where the resistance parasites are. But this also allows us, if the information is given that they reside in a neighboring country, for us to rapidly share that information with our neighbors so that we can have rapid containment measures put in place before we have a massive outbreak like the 2010 outbreak, 2000 outbreak that we had in the SADC region. So in conclusion, I just want to show, hopefully I've convinced you that the E8 surveillance units are critical to South Africa and the region's elimination aspirations, particularly if they can be added just to be able to increase malaria testing and treating, as well as to be able to add the transmission blocking drug, because then they can stop transmission as well as secondary transmission. And also they can be used to increase routine surveillance activities that are very essential given the rapid increase in diagnostic and antimalarial drug resistance. And it's really critical that we start now looking at having a regional genomic surveillance program within the region, where we start with basic knowledge first, now finding out whether our parasites have HRP deletions and what they are, whether they are sensitive or not to the drugs, and then add on to that the next level of what Davis was talking about in terms of genomics, so that we can actually look at parasite flow within the region. Thank you very much.
Thank you, Dr. Rahman. Thanks for also tying up a few of the different talks we've had this morning. Always entertaining listening to your talks. So now we've reached the end of our formal presentations. If there are any questions from the audience, please could you send it through via Q&A or chat? I see we have one question there, but before we kick off with that, maybe if I could ask a question that's probably on everybody's mind. So to the presenters, any of you could maybe answer this, Emo, particularly you. How has COVID impacted the malaria cases in the region? Is anyone able to maybe elaborate on that?
I can certainly take it for South Africa, or does Emma want to start?
Go, Sri.
Okay, for South Africa so far, well, let's just say because we had our first peak during the winter season, we didn't see it negatively impacting malaria initially. However, with the malaria cases beginning to increase now, we are seeing a very worrying trend where malaria is being forgotten by healthcare workers and only emphasis is being placed on COVID. So we're getting a lot of late presentation and which are rapidly transitioning into severe malaria and unfortunately death. So it's definitely impacting in a negative way with malaria, with healthcare workers not taking into consideration that fever could also be malaria.
Thanks, Jayashree. Emo?
Thank you, Jayashree, and also thank you for the question. I don't think we have concrete information for the region on this currently, but we are actually conducting a small survey amongst malaria control program managers to get a better idea of how COVID has impacted the services they are able to run and how that ultimately has affected malaria cases. We haven't got those in yet. From the few we've had, it doesn't look like it's had an immediate impact on cases. But I mean, I think as Jayashree has just said, there is a longer term impact, which could be severe. So we don't have a very clear answer on that at the moment, but we hope to collate this information. And it is somewhat impressionistic in the sense that, but I mean, we're trying to get it from the people who would know best, which are the program managers in the entire E8 region. So hopefully we will have that early next year, and we will certainly try to make it known and publicize it.
Okay, thank you, Emo. There's also another question for you that came on the Q&A. I think you indicated you would like to answer this question live. What drug is recommended for chemoprophylaxis against malaria? That's a general question.
I'm not an expert in this area, but I mean, there's doxycycline, mefloquine, and malarone, which are generally used by travelers, and obviously they have different costs. I think, I believe Eswatini has at least used this in the past to give through public health facilities. I think Jayashree might be able to say a little bit more about this. I don't want to put you on the spot or evade questions that, but yeah, I mean, I think there are standard chemoprophylaxis drugs for travelers, and the ones I've mentioned are the most widely used.
Yeah. I think, Jayashree, in your capacity as the chair of the case management committee, maybe you could enlighten us.
Sure, absolutely. So, Emma, you have definitely mentioned the most three popular ones, and definitely you also have to consider what is available in the country. And currently, South Africa does not have any mefloquine. There seems to be a nationwide or global shortage. So at the moment, we are not, for pregnant women and young children that want to travel for malaria areas, we are trying to ask them not to travel because that is not available. But the three you suggested are the most widely used, but generally in all malaria guidelines of countries, they recommend a specific drug that is available in their country. Thank you. Thanks,
Jayashree. I think that's quite a comprehensive answer. We have a question from ST Torok, and I think, Davis, this might be of interest to you. What is the optimal surveillance strategy for genomic surveillance for highly mobile patients and/or asymptomatic infections? David?
Thank you for that question. It's quite interesting that you raise that, because we actually do think, especially in elimination settings, highly mobile patients are people we actually consider high-risk populations, because they are the people who are moving about, and they are obviously, a source for the mosquitoes to transmit malaria. So what do I think would be an optimal strategy? I think to be able to collect samples from most high-risk groups, firstly identify your high-risk groups, collect samples that can be analyzed to confirm that these are high-risk groups as part of the surveillance exercise. And then this information is gathered routinely to identify which groups are the ones which are the source of malaria from season to season, because these might actually change. That's the first thing. Then the secondly, once you get those samples, I do think to be able to do some localized sequencing. I'm a big proponent of nanopore sequencing, to be able to try and do that in field if possible, and within season if possible, because that gives us some real-time data which can help us make decisions, including what interventions, are we getting an outbreak? There's all sorts of information we can try and get in real time, instead of collecting all the samples and sending them to a highly sophisticated centralized lab. I don't know if that answers the question.
Okay, a follow-up question to that, Davis, was how connected are the NMCPs and the labs?
I'll give an example for Namibia. We are highly connected. Our laboratories at the university are working very closely with the NMCPs. We have staff which work at both the NMCP and also at the university. So they do have total access to our labs. And it's an issue of resources on whether we can process samples in a timely manner with sufficient resources. But yes, there is a very strong linkage between what the NMCP is doing and what we're doing in the laboratory, and it's part of the elimination strategy.
Thank you, Davis. I see Power's got his hand up. I'm not sure if we can connect him. I need guidance from the Secretariat. Okay, while we're waiting for that, Power, please bear with us. Let me just continue with the other questions. Question from Ebong, and this probably is for you, Imo or Mukosha. The proportion of those who reported sleeping under mosquito nets was higher than the proportion who, wait, I seem to have lost that. Was higher than the proportion, I lost that.
I think the question was, it looked as if the proportion that use a net is higher than the proportion owning a net. And I can answer that, and I've just typed an answer to it as well, actually. It's the proportion using a net is out of all those who own a net. So in Angola, it's noteworthy that although only about 64% said that they own a net, out of those, almost everybody used a net. So 90% of those used a net. But that means out of the total population, those that have nets and those that don't have nets, of course, the proportion is smaller. So it is actually consistent. It is out of those who own a net, large proportions use a net. I hope that makes sense.
Okay, I think we can get a follow-up on that if it doesn't. Rebecca van der Meulen asks, many of the recommendations from the Border Post survey focused on messaging. Example, to encourage testing with fevers, to use protective equipment. Do we know that there are reliable stocks and access to these commodities? Is that one you can answer?
Well, certainly for testing, we don't have, I'm not aware of any reports that there have been stockouts at border posts. I mean, if they have occurred, they would have been very rare. So the messaging that if someone has fever, you know, there should be a suspicion that it might be malaria and they should be tested, can be implemented with what they have. I think messaging in terms of protective equipment, that is true. The border posts are probably not well equipped for that at the moment, to give people bed nets or other forms of protection whilst they're traveling. And that's why we've highlighted this as it's really a gap. We don't have a sort of a policy that is particularly directed at travelers. I mean, we will probably see more of this when we have the surveys amongst the migrants who are traveling almost all the time, where, you know, it is difficult for them to protect themselves against mosquito bites. And I think it's something we don't have a good answer to. How do these people get better protection? Because currently they don't have it. And even amongst the residents who travel, they take risks by sleeping outside without any protection. Thanks.
Okay, thanks for that, Imo. Jayshree, perhaps one for you. A question from Anonymous. Is there a defined PR threshold to consider border posts as feasible? I understand at some point they may become too expensive for smaller case identified. Any analysis on that? Cost per case in border posts versus cost per case with alternatives or other active surveillance activities?
Thanks for that question. It's really interesting. And yes, it's something that we should be doing, is costing it. We haven't done it yet, but at some stage, if we do manage to eliminate malaria, I think these surveillance units could be transformed into doing surveillance for other diseases. And it's something that we've already discussed, is making them a comprehensive package. So it's not only malaria that they focus on, but other diseases that might be important. But definitely the costing needs to be done and needs to be taken into consideration. Thank you.
Okay, thanks for that, Jayshree. And we've just got time for two more questions. So Davis, this question is for you. Are there plans for genomic studies across the borders of the E8 states or other countries, namely Angola?
I think in my presentation, I suggested that it should be the way to go where we are able to do this. I know in Namibia, we are prepared to work closely with Angola on a bilateral level, but I do think it would be useful for it to be an E8 approach and for it to be supported as such. I know there's a lot of conversation around use of genomics in infectious diseases coming from Africa CDC. So I hope this is something that we can do.
Okay, thanks. Perhaps the last answer to our last question to the three panelists. Are we, as a region, foreseeing any potential change that may be posed by the climate change while working on strengthening surveillance systems? If yes, what is it that we have to consider or beef up? That comes from Erika Swiswi. The panel.
Okay, I will go first with that then. Definitely, I mean, I do think climate change is going to play a big role, but I'm not quite sure which way it's going to go. We have some areas that some people are saying that we're going to get more mosquitoes with more rain, much in wider areas, whereas others are saying it's going to be too hot and we're not going to and it's going to be too dry. So what I do think is, so I really don't know which way it's going to go, but what I do think is that our surveillance systems have to be really strong to be able to pick up where the victors are and where the cases are, and be able to do that as an epi match, and be able to increase any interventions that are based on that. So that's my opinion for now anyway. Thanks.
Just to come in and support what Jayshree has just said, I know there's a big thrust from the E8 to build capacity in entomology, and this is absolutely important. With climate change, we are seeing changes in distribution of mosquitoes in areas where they went before, getting malaria in areas where they went before. And I think in 2017, we also what happened when we had the floods and there was malaria everywhere. So we really need to make it a priority. That surveillance is an important intervention as well, as far as malaria elimination is concerned. Whichever way the trend goes, we need to beef up surveillance.
Okay, excellent. Thank you. I think that's all we have time for. We've actually gone a bit over the hour that we'd allocated. So I want to thank all the presenters for their interesting contributions to the webinar. And thanks to all of you who have participated through the chat and the Q&A, and also just by being in the audience. So thank you very much. And I think some take-home messages are that we need to work more regionally rather than as country-specific programs. And I think, as most of the panelists highlighted, malaria is not a country-specific disease. It affects everybody in the region, and I think we all need to join the collaborative efforts initiated by E8. And I think together we can make a greater difference than we can as country-specific programs. Thank you, and goodbye, everyone.